Everyone. I hope you're feeling good this morning. Where I am in London, it's raining. My name is Agnes Bazwe. I'm the Chief Executive of the Africa Advocacy Foundation. And I'm going to introduce to you my colleague, a friend, a formidable lady, Deborah Alcock-Taylor. Hi, Deborah. Who is going to give us the opening remarks. But first, I would like to say a brief introduction of who Deborah is. Deborah is the Chief Executive of the Directory of Social Change and has worked in the charity sector for over 35 years. Among numerous other roles, Deborah is currently the Vice President of the Soldiering On Through Life Trust Awards and co-chair on the judging panel with the journal The Lord Dennett. Deborah is also a trustee of Unikind Direct, one of the Prince's Foundation trusts. She's also a trustee of the Berkshire Community Foundation, and I'm proud to say she's an ambassador for Africa Advocacy Foundation, championing the rights of women and girls at risk and affected by female genital mutilation. Deborah is also a renowned public speaker with many years experience of training and coaching, and also an internationally published author of several books on management and leadership. A few of her books are, I can just, give you just a little, but she's got a lot. It's Tough at the Top, The Pleasure and the Pain, It's Murder in Management, It's a Battle on the Board. That's the current book which I'm reading right now. She's actually trying to create understanding of how trustees can well or efficiently manage their charities. It's really a nice book. I would really encourage those who are in the management level of managing charities, trustees, to have a copy. Deborah also has a regular monthly column in the Third Sector magazine and has appeared on Radio 4, The Moral Maze. Deborah wears a lot of hats. This is just a brief, and it's really a pleasure to introduce Deborah. Over to you, Deborah.
Thank you, Agnes. I have to say, of all of those things, the thing that brings me the most joy and pride is being an ambassador for the Africa Advocacy Foundation, who, for a small charity based in South London, have the most incredible reach and impact of almost any organisation I know, and I'm so really proud of them. And I'm really proud of this initiative today, actually. One of the things that matters hugely to me is this notion that we all support each other. My own charity, we believe that the world is better when people get together and support each other, when we get off our own sort of stories about what our lives are like and we care for and support other people. And I think the Africa Advocacy Foundation is absolutely a fantastic example of that. And this initiative today, which is all about things so close to my heart, which is about collaboration, how you can achieve so much more coming together and working together and sharing and not being precious about our own little bits of the world and really caring for others. The particular issues you're dealing with today are not ones that I'm personally an expert in, but I got very, very well briefed, of course, by the fantastic Dennis. And, things that obviously you all know because you're here at this conference today talking about it. But, the fact that migrant communities are one of the key populations that fare worst in terms of health outcomes and social injustice. These are things that we're kind of, vaguely aware of in the background when we're listening to the stories or watching the news. But actually, when you can gather data together and make the case that this is a real challenge, and certainly I know we're talking today about Europe, and the fact there are so many barriers, often completely unnecessary, silly barriers to the ability of migrants to access the support that they need and the information. Some of the support is actually available for them, but they have no idea how to go about getting it or how to touch that support. And in other cases, the support is denied to them. And that's where we have work to do to campaign and to try and find a way to get through those things and to make the changes that are so desperately need. And I know that this is one of the things that AAF have been working on really hard with other organisations, many of whom are here today. It's also, you know, this interesting thing that the fact that, you know, so many migrants, when they arrive in Europe, are healthy and well and happy, actually, or, you know, relatively happy. And then they come into our part of the world where we're supposed to be welcoming, wonderful, and we sort of somehow or other we damage them. They become less healthy when they come into our space. They become less happy. They weirdly feel less supported. How can that possibly be right? That makes absolutely no sense to me, given the kind of sort of, you know, things that we purport to stand for and the values that we say that we want to hear. They suffer from overcrowding, lack of sanitation, often much more likely to be put in really, really difficult situations where they're more likely to catch diseases or illness. I mean, certainly we've seen this in the pandemic, haven't we? Some of the ways in which we treat our fellow humans is just quite shocking to me, and something that I find incredibly difficult to understand. But the point about it is that whether one understands it or not, what you need is groups of people getting together and saying, this is not okay, and we need to do something to fix it. And this is absolutely the thing. I feel the strength and the warmth, you know, here today of people really desperately wanting to do something about it. Because, you know, fundamentally, it's about human beings being human. And I don't understand why any of us would ever think that we couldn't treat our fellow human beings in the same way that we'd want to treat ourselves. And never mind that, actually, it just doesn't make economic sense. You know, Dennis makes the argument to be very strongly that when we don't treat our migrant communities in a healthy and fair and equitable way, it costs us more. It costs more to treat a crisis than it does to make sure that people have access to the information support they need when they first come. It costs more from a public health perspective if we put people at risk and then we're not finding ways to support them. And it generally costs more the fact that we're having to put in more effort to fix a problem that actually we created, and it just doesn't make any sense. And this is why this conference today makes so much sense, that you're coming together and you're talking about collaborating, you're talking about how we can all work together basically for our fellow human beings. Honestly, I'm so excited about this initiative. I mean, when Dennis was sending me the briefing, I'm like, this just sounds fabulous. I can't see how it can possibly go wrong. So, you know, I'm trusting you all to get this to be absolutely right. You know, I always talk about hope. One of the things that, you know, Agnes and Dennis will tell you that is my message always, is that those of us who support other people, those of us who run charities or work in the public space, our job is to be purveyors of hope. If there's nothing else, we have to give people hope. But actually, hope isn't enough, because hope doesn't change the world without action to go along with that hope. So you have to be hopeful, and then you have to back up that hope with the actions and the things that you can do to actually make things forward. And my experience of being an ambassador for the advocate oh dear, it's Friday morning, I'm very tired, for the Africa Advocacy Foundation, is that they magnificently combine the two things in all the work that they do. And clearly in this one in particular, what they do is they offer hope and then practical action so to deliver on that hope. And that, I think, is my core message to you all today. One of my favorite quotes is by a chap called John Dryden, who's a very old British poet and writer. And I won't bore you with where it comes from, but I just really love it, because it goes, I am wounded, but I am not slain. I shall lie me down and bleed a while, and then rise to fight again. And I think these actions and these things that we're taking are exactly about that. They're about rising and moving forward and never, ever giving up in the face of adversity, because the people we are serving, the communities that we care about, they deserve the very best of us. And I feel really confident that that's what they're going to get out of today. So thank you so much, Dennis and Agnes, for letting me be part of this. I'm really sorry that I can't stay for the whole day. It is my day off and I'm going to get my hair done. I'm sorry, priorities, you know, when we've been locked away for months on end. And I hope it's going to be a fantastic conference, and I wish you all the very best of luck. Bless to you all.
Thank you very much, Deborah. Thank you for such a very uplifting and really inspiring, talk. We really wish you well for the day. I know you had a packed day, but you managed to get time to come and be with us. So we're really grateful. Thank you so much for that. So we're moving on to the second bit, which is where I'll be providing an update on what my health is. And I have a few slides to share. So basically, we decided to initiate My Health platform based on a number of conversations we've been having in the community around the needs of migrants. And it was a conversation that has been in the making for the past 4 or 5 years since we initiated My Care, which is the training program that we've been running with the support of Gilead Sciences, MSD Europe, and Viv Healthcare. So, as you know, Africa Advocacy Foundation has been around for 25 years. Our passion is trying to get everyone to access health, education, and social services that they require. So when we initiated My Health platform, it was mainly aimed at trying to ensure that refugee communities or migrant communities in Europe have access to best healthcare, especially because we have seen that a lot of people are having very poor health outcomes. And so the aim really is to just strengthen the capacity of migrant communities, because we've seen that there's a lot of gaps in terms of how we collaborate, how we share information, but also how services are accessed. And some of the barriers that we experience around legal and regulatory issues, and as well as how some of the structural issues around healthcare access really stems from the fact that a lot of organizations don't have capacity to be able to advocate effectively or to be able to support or design services effectively. So this platform was seen as a way of trying to get everyone to work together so that we could share best practice, we can actually support one another, and we can initiate some advocacy strategies that make sense. By that, I mean advocacy strategies that actually reflect what policy is talking about. So how we can influence policy and connect it to grassroots experiences. Our vision, of course, is for Europe, where migrants are able to live healthy and safe lives. And also, we just want to be able to make sure that we have inclusion and that services really reflect the needs of people at community level. Next slide, please. And so we have 4 components of My Health. One of them is Policy and Research Working Group, which is still in development. We haven't actually had anyone there because we would like it to be a co-produced initiative. So we would like to have people who are experts in policy, who are advocates, who are passionate about equality, joining this research and working group. And it stems from the fact that there's need to build evidence and data. There's serious gaps around data on migrants, and I think that's really, really important. One of the aspects, as you know, is that, and as Timo will highlight, is that a lot of migrants get infected with HIV when they've arrived in UK, and this is really worse for men who have sex with men who are migrants, which goes up to around 72%. So I think that that data is not there to support this kind of insights that we see, and it's important that we have that. The capacity building aspect of it is what I mentioned earlier, that has been supported by MSD, Gilead, and Viv, and we've been training annually 20 advocates from about 3 years ago, and it's aimed at really trying to build capacity of migrant communities to have access to services. And so these are community leaders that are forming the second aspect, which is community of practice. This is made up of people who have trained on MCare, but also people within the communities who are working with migrants, who are leading organizations to become part of the community of practice. And then we have a resource directory which we have developed that we are going to show you today. It is a work in progress. It basically has a group or a list of organizations, a list of services, and migrants can access it very easily. So can I have the second slide, please? I mean the third slide. Yeah, so this online resource we've developed, we have so far had 94 organizations signing up from 32 countries. Of course, because of GDPR, we just don't go on the desk, and on the internet and search for the details and list them there. No, we actually contact organizations. We work with our MCare participants from previous years who live in various countries to help us do the research, to help us contact organizations. And sometimes they're very small organizations that may be just community churches or community groups that don't necessarily get listed on the internet, but actually are supporting people. So we are doing a lot of research and it's work in progress. If you know of any organizations that are supporting migrants in your own countries, please let us know. Our contacts are there. And the directory actually has a summary of healthcare rights and protections in every country. It has details on HIV/AIDS resources available, as well as advice, information, counseling, and mental health. Can I have the next one, please? And so that's how it looks like. We've got a way, it's optimized for mobile use because we realize that most migrants actually access services, information on their mobile phones. So it will have where they say they can find help and they can actually use the map depending on which country they are. And they can search for a list of services. So you can, if you go to myhealtheurope.org, you will see it's a website which is still in development. So please bear with us. If something is not perfect, we will kind of try and sort it out. Next slide, please. So we want to work with you, want to collaborate with you, but the structure of My Health is just that we are hoping that organizations that we are working with are going to make decisions about this network. So we are going to be able to have our first meeting in November of all organizations, and we're going to do elections there where we're going to get a steering committee. We also welcome people to join the Independent Advisory Board, and this, you don't have to be a migrant, you don't have to have a migrant background. We just want people who actually can enable us connect well with policymakers, with institutions, and with services so that we can actually have meaningful strategies that can actually impact change. We also have working groups which are going to be composed of community of practice, and this is going to be around research, around training. So we also welcome people to join this, but members who are organizations that are members of My Health will actually form part of these working groups. Next, please. So we welcome you to collaborate with us, whether you're an academic institution, you're a think tank, a policy body, institutional bodies, civil society organizations. We are launching today not because we've done everything, it's just because we are trying to initiate something, and therefore it is not already work done. So we want you to work with us. Please reach out if you have any projects that you want to run. If you have any ideas around how we can best serve communities, please let us know. And I just want to end by thanking my team at My Health, and Flahati Gupta and Juliet Emmanuel have done fantastic work to make us realize today. So I really want to say thank you to them. I want also to say thank you to our current and past MCARE graduates and trainers, because they have been very central to shaping up this idea. And finally, I would like to thank Gilead Sciences, MSD Europe with Healthcare, and who are funding My Care training and have been funding it for the past 3 or 4 years. And I also would like to thank very much the Open Societies Foundations that have actually enabled us to get My Health off the ground and have it running. Thank you very much. That's my presentation. And I would like to take this opportunity now to introduce Bernadette, who is going to run the next session. And Bernadette is a medical graduate from St. John's Medical College in India. She has a doctorate in epidemiology and public health from University of Oslo, Norway, and a postdoctoral research fellowship from the Institute of Psychiatry in Oslo as well. Kumar has several years international experience working for UNICEF, WHO, World Food Programme, World Bank, and NORAD in Southern Sudan, Somalia, Northwest Kenya, West Bank, Gaza, North Korea, China, and Bhutan. Migration and health has been the focus of our research since 1999, and she's the co-author of 2 books, Immigration Health in Norway and A Primary Care Perspective. Migrant health, she was appointed director of Norwegian Center for Migration and Minority Ethnic Health, associate professor, also Global Health Institute for Health and Society in University of Oslo. She is a professor of the Empower School of Health in India and affiliated professor at Kathmandu University, Nepal. She is the president of European Public Health Association section on migration and ethnic minority health, and leads the Migration Health Work Package of the EU Joint Action on Health Inequalities. Kumar was the Lancet Commission on Migration Health chair and is a co-chair of Lancet Migration. She is also the chair of the Global Society of Migration, Ethnicity and Race. There is no better person to lead this next section than Bernadette. So Bernadette, you're most welcome.
Thank you so much, Dennis, for that extremely generous introduction. And it is really my pleasure to be here today and an honor to be able to be with all of you today. So thank you so much for the invitation, and thank you so much for allowing me to be able to facilitate the workshop and the conference today. I would like to, continue quickly, because I know that time is of the essence, and I'm sure that you're all waiting to hear our next speaker, and actually the first speaker for the day. And it gives me great pleasure to introduce our speaker, the Right Honorable Lord Boateng, a civil liberties lawyer, brought up in Ghana, MP in Britain 1987-2005, one of the first Black MPs and the first Black member of any British government, serving as Minister in Department of Health, becoming Minister for the Police and Prisons, and then in Cabinet as Chief Secretary to the Treasury. And then he continued to be a member of the House of Lords from 2010. He's currently a member of the House of Lords, International Relations and Defense Committee. He's an independent non-executive director of the Ghana International Bank in the City of London, and serves on the board of the Singeta Foundation for Sustainable Agriculture in Switzerland. He's also on a number of charities and also on the advisory board of a number of organizations, public, private, non-for-profit, working in Asia and Africa. And if I begin to actually talk about all the work that he does, we'll be here until tomorrow. But I would also like to say that Lord Boateng is a Methodist lay preacher and chairs a number of charities, including Book Aid International, and he's Chancellor of the University of Greenwich. So I think you'll all agree with me, we couldn't have got a better speaker to kick off today. And what you're going to talk to us about is the importance of legislation. So over to you, Lord Boateng.
Thank you very much, Bernadette, for that generous and fulsome introduction. It's good to be with you all. But and Agnes and Dennis will know this, that in our tradition in Africa, at least in a part of Africa in which I was brought up, in the Akan tradition, when somebody is introduced to the village, to the community, it's not so much a question of their name or their titles or their various attributes and contributions that is central to the introduction. It's not any of those things, but the chief's linguist, by way of introduction, asks one question of the person to be introduced. And that question is, why are you here? Why are you here? Which, if you think about it, is the best possible question to ask by way of introduction. And I am here as a legislator, but above all as an activist, to salute you all, to support the originators and the funders of the MI Health platform, to welcome this important initiative and the work of the Africa Advocacy Foundation in bringing it to this place of launch and inauguration, to do all of that, but also just to say a few words about the context into which this platform is being introduced and the challenges it throws up, and the role of legislators and legislation in that, and how legislators and legislation needs to respond to the challenges of these times, and also, and importantly, to you all as practitioners and as activists in this area. And in doing that, I think it's worth just spending a moment reminding ourselves of the framework, the legislative framework in international, regional, and domestic law, which applies in terms of healthcare and addressing health inequalities. Because it goes back to 1948 and the very foundation of the World Health Organization. It's been developed in successive conventions and treaties of the UN and within the UN system ever since. Also, and importantly, it is central, the primary EU legal base recognizes the centrality of ensuring a high level of human health protection in the definition and implementation of all the EU's policies and activities. It's contained there under the headline "Health in all policies." So you see successive directives of the European Union addressing this issue. Interestingly enough, whilst the EU legal system prohibits discrimination on grounds, and I've got it in front of me, on grounds of religion, belief, racial or ethnic origin, sex and sexual orientation, when it comes to non-discrimination in access to healthcare, EU secondary law provides protection against discrimination only on the grounds of racial or ethnic origin and sex. So that the issue of discrimination in healthcare on the grounds of religion or belief, gender identity, and sexual orientation isn't actually specifically addressed by EU secondary law. So there's a gap there, and there's a gap there that needs to be addressed by legislators. Also, and significantly, it's worth looking because Europe, of course, isn't to be defined by EU law alone. The Council of Europe embraces that wider Europe, of which the UK, Russia, just to take two examples, are a part. And the Council of Europe, too, in its founding documents, addresses the issue of healthcare and health inequalities. And as recently, and this is highly significant in terms of the launch of the MI Health platform at this time, as recently as May of this year, the Committee of Ministers of the Council of Europe signatories have adopted an action plan on protecting vulnerable persons in the context of migration and asylum in Europe. And they have established this action plan to run from 2021 to 2025. And I really commend it to you as the basis of your discussion with legislators and ministers in your respective countries at this time, because it commits the ministers, and I want to quote here the exact words of the Secretary General of the Council of Europe. It commits the ministers to this: migrants and asylum seekers have particular challenges in the COVID pandemic, notably access to healthcare and vaccinations. This is the commitment that the ministers made, we are increasing cooperation among member states to protect the most vulnerable persons. We are increasing cooperation amongst member states to protect the most vulnerable persons. So that sentence ought to be the basis upon which you hold legislators to account, and that we as legislators in our respective national legislative bodies, as well as in the Council of Europe, the Parliamentary Council of the Council of Europe, as well as in the European Parliament, it's on the basis of the commitments made there that legislators need to hold ministers to account. Because the reality is that in these times, the issue of inequalities in healthcare has been highlighted by the COVID pandemic. The disparities that exist real disparities in my own country, in the United Kingdom, in terms of Black and ethnic minority women in their healthcare, in terms of death in pregnancy. You're more likely to die as a Black or ethnic minority woman in pregnancy than any other sort of women in terms of race and ethnicity. Likewise, in mental health, in cancer, in every area of treatment, and in every condition, Black and minority ethnic people are less likely to have favorable outcomes than their white counterparts. When you add to that the issue of poverty and the issue of questionable status as migrants or refugees, hesitancy in coming forward for treatment in terms of concerns about what the consequences will be for them in terms of immigration status of so doing. When you add all those factors together, the picture is even worse. And so it requires a response. It requires a response rooted, of course, in the legal framework, but also, and importantly, it requires a response in terms of resourcing. And what we know is that resources are best spent when they are guided and when they are influenced in terms of their distribution by the knowledge and the capacity to engage that is held within grassroots Black and minority ethnic organizations themselves, organizing autonomously, organizing as patients groups, organizing as community organizations. We know that when health authorities, primary, secondary, tertiary, when they engage with those groups from our community, those organizations from our communities, that they are more likely to spend their money effectively, they are more likely to enhance and increase their reach, and they are more likely also to have a positive impact. Now, that needs to be the basis upon which ministers engage with this issue in terms of the allocation of resources. That needs to be the basis upon which we as parliamentarians in our respective parliamentary committees judge the effectiveness or otherwise of public spending. And you all, as grassroots community activists, practitioners, and policymakers in your own right, need to be heard, and need to make sure that there is your voice present around the table where these issues are considered. Now, that doesn't just happen. That happens because of organization. And I applaud all you have done to bring the platform to this point. It now needs to be the basis of yet more organization, because as we know, power concedes nothing without a demand. It never has, and it never will. You know, that's what Frederick Douglass taught us at the end of the 19th century. The Black American freedom fighter. We know that to be the truth. We know that healthcare inequalities are persistent and are impacted upon by racism and underpinned by racism. That we know. W.E.B. Du Bois, the great Pan-Africanist and intellectual operating in the United States, operating in Europe, operating in Africa. When I was a little boy, I visited W.E. Du Bois's house with my father. I sang at his funeral. Now, his original doctorate, as a number of public health specialists amongst you will know, was on health inequalities based on race in the United States. And he was the first Black to obtain a PhD in the United States at the beginning of the 20th century. Those inequalities persist, and they need to be addressed by activism. They need to be addressed by legislators taking on board all that this platform will throw up in terms of lessons to be learned. And let me just end, if I may, on this note, by suggesting, well, I'll take just a number of areas where we need really to move some obstacles that exist at the moment to going forward in this area. First, and importantly, the issue of data. You know, we need the data, and there are legislative blocks to the collection of data that reveal the extent of the inequalities that need to be removed. That's our responsibility as legislators, but it won't happen unless the demand is made for data and collecting data based around ethnicity. And I know that can be contentious. I know it can be difficult, but all the experience that we have in the UK, where despite some drawbacks we nevertheless collect data now on the basis of ethnicity, and it has proved to be invaluable in terms of addressing these issues. So data, very important. Secondly, I think we need to recognize as well that public health and health inequalities in relation to migrants, to Black and minority ethnic people isn't just an issue of moral significance and importance. Isn't just a legal obligation. It's also an issue in these times of global pandemic of national and global health security. And it needs to be given that priority. And we need also to think always of the impact of our actions as legislators on the most vulnerable. And I end on this note. You know, I'm speaking to you now just 15 minutes walk away from a place called Napier Barracks. Now, Napier Barracks is a place essentially where people who have made the crossing, the dangerous crossing of the Channel, but before that have made many other dangerous crossings across the Sahara, across the Mediterranean, where people who come to this country without documentation are effectively interned. They are interned in a camp that has been successfully and successively challenged in the courts for its failure to address healthcare needs in terms of COVID and in terms of mental health. Yet it still persists. It still persists to this day. So local activists, Black, white, migrant, non-migrant, are campaigning to address this issue. Legislators are raising it in Parliament, and it is that sort of activism that is the best guarantee of addressing issues around health inequality and injustice. Because, you know, hope, we've heard reference to hope earlier on. Hope, has St. Augustine told us, St. Augustine of Hippo, St. Augustine African, because Hippo is in North Africa. St. Augustine of Hippo said, hope has two beautiful daughters: anger at the way things are, and the courage to do something about it. Anger at the way things are, and the courage to do something about it. I applaud your anger, and I applaud.
Thank you so much.
Good luck.
Thank you so much, Lord Boateng. And that was a very good way to set the scene for this particular webinar. And we really appreciate all the insights and painting the big picture for us. I hope you'll be staying with us to reflect on some of the questions that have come up in the chat, and we'll take them in the Q&A section. So thank you very much, greatly appreciated. Moving on, we're now going to have the first speaker of the panel. And the first speaker of the panel is a person who is going to talk about his own experience, Moro Yafa. And he's really going to talk about the issue that we all refer to, nothing about me without me. Moro Yafa is a radio host, producer, human rights advocate, founding member of We Are Born Free, and a board member of the Radio Network Berlin. He uses social media to raise awareness and conducts lectures and workshops and focuses on gender equality, empowering women, minorities, and refugees especially. And we know that the most important part of his work is not only raising his voice for himself and those who cannot, and of course, never underestimating the power of your voice. So the floor is yours, and you have 5 minutes more, so I hope you can stick to the 5 minutes, not 15. Thank you.
Thank you so much. Thank you all. I greet all of you. And thank you to Dennis for making me be part of this panel today. I mean, most of the time it's always like people talk about migrants experiences, but today, me as a migrant is here to brief you about what does it mean to be a migrant. I mean, unfortunately, I am given only 5 minutes because my story is more than even a year. I can narrate full story because I have been in this journey for almost 12 months, almost a year. I came through this perilous journey. You know, I have encountered so many difficulties, and in this asylum process here in Germany, in Berlin, I could speak a lot, but unfortunately, I would just summarize a bit to you about me as a migrant, or what does it mean as a migrant coming from sub-Saharan Africa through this perilous journey. So my name is Moro Yafa. I come from the Gambia. I have been living here in Berlin, Germany for 6 years. I am one in hundreds and thousands of people who took this dangerous and deadliest route to reach Europe from Africa. Many have died in Sahara Desert. Many have died being enslaved, raped, and tortured in Libya, and many more have perished in the Mediterranean Sea. Most among us who have arrived here in Europe have arrived with post-trauma, psychologically, physically, and mentally disorders. Expectantly, our arrival in Europe would change and heal our wounds and wipe our tears of sorrow and horror throughout the journey, but unfortunately not. With our arrival in Europe, we, the migrants, most especially from sub-Saharan Africa, have to be re-traumatized again through all what we have gone again. Upon our arrival in Europe, we have to be re-traumatized again and undergo many challenges on our asylum procedures and systems. A system that makes us vulnerable physically, mentally, and psychologically. Here in Germany, being a refugee or migrant, despite all that we have gone through in our journey, we have to be socially isolated from society. That means living in remote areas outside society, outside people in the asylum camps. Living in everyday fear of deportation, fear of all sort of asylum complications, lack of proper accommodation, and lack of sanitation. Become undocumented, lack of job opportunities. Already you are living in the camp, you become undocumented, you cannot have access to go to school, you cannot have access to work. So you are totally out of being job. Become homeless. If you don't have document, you don't have work, you don't have money, so you will become homeless because you are unable to pay your rent. You will be totally kicked out of the asylum camps, which also being homeless, which also correlate to drug consumption. Because if you are already homeless, you have no place to sleep, you sleep outside, so it influences you to go on drug consumption. After that, no access to medical treatment. Already in Germany here, if you are undocumented, you have no document, you have no access, already you are totally excluded. You are automatically out of medical treatment because already been undocumented. All these are impacted on us by social, physical, and mental health disability of what we have gone through our journey, through on what we have to undergo during our asylum procedures here in Europe. To provide, improve, and empower us, the migrants, we need proper acknowledgement and acceptance of our backgrounds and stories, because most of the time, our stories and backgrounds are never accepted and acknowledged. I would not say they don't hear. Everyone hears about it. Everyone living in Europe hears about it. Because every time in the news you hear how migrants are reached in Europe, how they are going through. So I think in order to improve and empower us, the migrants, we need proper acknowledgement of our problems, of our stories, of our sorrows and horrors, of all what we have gone through. And acknowledgement, acceptance goes with it in order to be given fully social, legal, physical, psychological, and mental health support, regardless of our race, regardless of our color, regardless of our gender, and regardless of our status. Together, we prioritize health before empowerment. This is what I thought. I thank you all for your kind attention. Unfortunately, it's just 5 minutes. Otherwise, it would be really great to narrate you all the stories. But as I said earlier before, my story will be narrated more than a year because I've gone through a lot. I thank you all, and it's a pleasure and honor to be part of this panel. Thank you all.
Sorry, you're not able to hear our applause. Any applause would be little for what you have shared with us, and you really made migrants from being a faceless, nameless group into human beings, and the whole humane aspect of migration and what migrants face is so important. So thank you for sharing that with us, greatly appreciated. I'm sure there will be questions to you, Moro, and we'll address that when we come to the question session. Now moving on to our next speaker, and our next speaker is a colleague who is known to many of you, is Timur Nouri. He's an expert in HIV and migrant health, is a psychologist actually who works at the European Center for Disease Prevention and Control, and is an expert on monitoring and evaluation. He has been primarily responsible for monitoring the HIV response in Europe and Central Asia, including monitoring the continuum of HIV care and supporting efforts to monitor the response to viral hepatitis in the EU and EEA. Besides this, recently he has been working on guidance on screening and vaccination of infectious diseases, as well as he's been involved in guidance on infection prevention and control of COVID-19 in migrant and refugee reception centers, and most recently reducing COVID-19 transmission and strengthening vaccine uptake among migrant populations in EU and EEA. So as you know, Timur is really an expert, and we're very fortunate to have him with us to talk about migrant health data highlights. Timur, the floor is yours.
Thank you so much, Bernadette, for those kind words. So please project the slides. And while we wait for them, I just want to echo what Lord Boateng said on the outcomes of all health issues related to migrants are always poorer. And every disease I've looked at the DCDC, including now latest COVID, migrants always come out poorer when it comes to everything. In this COVID report that we just produced last week, migrants are disproportionately affected when it comes to cases, hospitalizations, and deaths of COVID-19, and have much, much, much lower rates of vaccination coverage. So this is just an endemic situation that we need to address. So I'm going to focus on HIV. Please, the next slide. So as you know, looking at the data for the EU when it comes to HIV diagnoses, we see that migrants are a key population for us. 44% of all diagnosed cases in the EU in 2019 occurred among people who are born abroad, and this is how we define migrants in our surveillance data. Next slide, please. So in order to really achieve epidemic control in our region, we must scale up interventions targeted towards migrants. And that's something that we are not doing. And I'll explain a little bit why in the next couple of slides. Next slide, please. So this distribution of the 44% distribution in our region looks very uneven. So at the top here, you see some Nordic countries, Iceland, Ireland, Sweden, Luxembourg, etc., where more than 70% of all diagnosed cases in any given year, this hasn't changed a lot, is above 70 or 80%. So migrants account for a significant proportion of diagnosed cases in many countries. And as you see in the bottom here, in the eastern parts of the region, of course, that's much lower. And this depends very much on the migration flows to Europe, where migrants are coming from, of course. But what is really important to stress here is the fact that not all these migrants are coming from sub-Saharan Africa, which I think a lot of policymakers think so, and that they're coming already infected. As you see here, we need to look at where they come from. And in many countries, they come from Central and Eastern Europe, Latin American, Caribbean is really important, as well as Southeast Asia. So we need to look at where migrants are coming from. Next slide, please. Another thing that Dennis talked about in his opening remarks is, where do migrants acquire HIV infection? As I said, many program leaders here in our region think that migrants are already coming infected with HIV, and therefore they're not tailoring prevention programs towards them. So important research in the UK 5-10 years ago said that we need to be looking more carefully at this, and we produced a number of publications trying to look at this, and looking at CD4. Usually how this is measured is when you sit with a doctor and the doctor ticks the box, yes, you're probably infected in Zimbabwe if you are from Zimbabwe, and they don't feel comfortable talking about this. But clinicians have said this is wrong, they're underestimating this, develop a more objective method. So we're looking at CD4 counts at time of diagnosis and when a person arrived to a country, and we get very different data. Next slide, please. So this is just one study, but there's many studies now in Europe showing similar patterns. So this is a European funded project that looked at post-migration HIV acquisition, including more than 2,000 people. And this is here, among these people in this study, it was estimated that more than 60% were assumed to be acquiring HIV after they arrived to the EU. And this is something that Deborah talked about before, that they come healthy to Europe, but then while they're in Europe, there's many barriers to accessing care and prevention, and they become much more vulnerable. And as you see here, there are variations in different countries, but still, in the many studies that there are popping up now, this number seems to be confirmed. It's anywhere between 30 to 70%, depending on which country we're looking at, that they get infected after arriving to the EU. So this is really, really important that we develop prevention programs. Next slide, please. PrEP is a really important intervention now. As you see here, there's a clear west to east gradient in terms of where PrEP is available, nationally available and fully reimbursed. Many countries in the West, in the dark countries here, which have had PrEP programs now for 5 years or so, are reaching white gay men. They are not reaching other populations, and mainly migrants or sex workers or people who inject drugs or women, etc., etc. But migrants are not being reached. Even in the UK, who is a very well-established program, in France, in Norway, etc., they are reaching a certain demographic, and it's not migrants. So we really need to scale up prevention programs targeted toward our communities. Next slide, please. As you know, the SDGs, the Sustainable Development Goal, about the 90 targets now, the testing and treatment targets. We have great data when it comes to this for the general population. But if you go to the next slide, we are trying to ask countries now if they're able to disaggregate this by key populations. And here you look at the data availability on these targets when it comes to migrants. So we've followed this for a number of years now. And if you look at the right-hand side where it says 2020, the green bar shows you the number of countries that actually have estimates on the number of migrants living with HIV, only 8 countries. The red bar, where it says diagnosed, that's the first 90. So out of those, how many have been diagnosed? Only 13 countries have data on this, 10 countries on people who are on treatment, and only 7 countries have viral suppression data disaggregated by migrant status. And the last bar where it says only 4 countries are able to have the 90 targets for migrants out of the 55 that we're collecting data for. So this is a real issue around data, and we're trying to support countries to improve these estimates going forward. Next slide, please. So another key issue, of course, is treatment. So we're talking about reaching these targets of treatment and viral suppression for the general population, but there is one group that are not going to be achieving this, and that's because they're not even entitled to treatment. More than 50% in countries in our region do not even have legislation in place stopping them from getting treatment, which is, you know, a real shocker that this is the case in our region in Europe and Central Asia, and that's something we need to do something about. Next slide, please. So to end here, we will not be reaching these sustainable development targets unless we address certain gaps. And these are the gaps that we've identified for the general population. There's a prevention gap, there's a testing gap, a huge treatment gap where only 1 in 2 people living with HIV are receiving treatment, and a huge stigma gap. And we're trying to address this. We don't know what's going on in stigma, and we are working with the community now to find this. Next click, please. Next slide. The point here I want to make is that we have even greater challenges to address these gaps for migrant population. And this is in part due to the lack of disaggregated data, which the Lord talked about. We need to put out this data so we can address these issues going forward and affect policies and prevention. Next slide. I think that's finished there. So thank you very much.
Thank you so much, Timur. And as always, very clear, very concrete, and also dispelling some of the important migrant myths. Really appreciate that, and really putting into practice why data is important and why we need that. We'll come back to questions later. And I move on to our next speaker, who might be known to a lot of you, and she should be known to a lot of you. And I'm just going to call her Jum, because as you know, her name is very complicated. Jum works for WHO Health and Migration Program, Office of the Deputy Director General, WHO, responsible for regional and country support and partner coordination. She's actually worked with refugee and migrant health programs for the last 3 decades or more, and within the International Rescue Committee, UNHCR, WHO, serving refugee populations in Bangladesh, Jordan, Myanmar, Pakistan, Sudan, and Thailand. So she's really a person who has both the field experience as well as working at the global level and at the level of headquarters. She has served as UN coordinator for avian and human pandemic influenza preparedness and response, and coordinating the UN country team. So I think without much ado, I'd like to turn it over to Jim. Jim, the floor is yours.
Oh, thank you very much. Unfortunately, I have to leave in 2 minutes. So I have to go and defend my vaccine guidance with the guidance review committee. But thanks so much for a very inspiring talk or discussion today. As a migrant myself for over 3 decades, indeed, it's very impressive to hear all of you. So with WHO, I'm been asked to talk a little bit what WHO does, and also the challenge that we see. We hear a lot today already about the challenge facing with migrants themselves, but for us here, what WHO does. So for us here, we have been working with member states, with partners, in setting up over this number of years in developing a policy intervention. We have the World Health Assembly resolution that passed that to address guiding how to address the health of refugees and migrants. This also includes the Global Action Plan 2019 to 2023. And with this one, as you know, also in the European region, you also have the regional action plan and strategy for refugee and migrant health, which in fact will run into expiry next year. The discussion on the what will be next priority, what will be the next plan, we already started. There will be a high-level meeting in Turkey in November this year to discuss that. So with us here in the headquarters, in the global level, we of course, within those of you who know WHO well, we have the 13 global program area of work, where you have heard about the triple billions target to meet. We have the issue of refugees and migrant health well embedded into this triple billion. And so with this one come through with the establishment of the health and migration program, the global program. So this program had 5 areas, core functions. One is on provide leadership, facilitation, coordination. So we work closely with partner UN Network on Migration, IOM, UNHCR, and all of this to try to really promote the health, the equity. Hi, just a minute. I'll tell my next meeting. I'll be late 1 minute. Hi, Rebecca. Could I be late for 2 minutes? I'm just speaking right now. Just 2 minutes.
No problem.
Thanks. Okay, all right, I have 2 more minutes. So with this one, we've been working, and the last few years, been quite active in the global migration and atmosphere, where you have the global compact on refugees, one for migration had been endorsed by member states, and that our task was to ensure that health is included in both global compacts, in the global discussion, so that with that we succeed to put health at the forefront. And the pandemic, you see the pandemic, when there's a lot of suffering there, but at the same time, it's also given there is an opportunity in there, in the sense that you see more awareness on health of migrant, where we do not see much before. Another one that is our key core function of the WHO is on the data. On data. You have already heard many of you talking about data. This is one of our core function for data research, health monitoring, to ensure that to know what's actually happened, and that would be best as evidence for policymakers to make decisions. So with this one, yesterday, I think some of you, I don't know, have already participated in the launching of our first global evidence base on the impact of the national policies on refugees and migrants with regard to COVID-19. So with this one, we have a series of global evidence base that will come out in the near future, including one on immunization. Another of our core function is on setting norm and standard, producing policy guidance and tools and all of this. So what you will see coming out soon is a toolkit that for one stop for healthcare providers, for policymakers, for partners that provide the repository of guidance and tools that's useful for refugees and migrant health. Another one is, of course, we cannot do all of this without country support and technical assistance to the country. So this is where we have been working now closely with the member state and partners, in particular to scale up the activity in the African region. And last but not least is on promoting multi-sector, multi-country, multilateral, intergovernment, inter-regional, and global coordination. This one we've been working with the UN Network on Migration. We lead one of the working group that deal with access to services. This is on the objective 15 of the Global Compact on Migration. So with this one, I think we are moving out there. We see a lot more interest, a lot of more advocacy on health. In vaccine, we see a lot more inclusion of migrants in there, but now it's how to address the barrier, how to address the challenge that we have. So with this one, I will have to end because another group is waiting for me, but we look forward to work for this network in the near future, because as you can see, many of our core function, I see that it's already your area of work is also fit with our core function. So we look forward to work with you. If there's any answer, you can send by chat and I can answer later. Thank you very much. Bye-bye.
Thank you so much, Jum, and very important to give us that overview of the initiatives and of what WHO initiatives are, both at current moment in time and also what is planned in the future, and what are the tools and other reports that will be available for everybody. So thank you very much for that. Moving on to the next speaker on our panel, and the next speaker is Melody Ledwon. I'm not sure, Melody, that I'm pronouncing your name properly, so please forgive me for that. She is a program officer in the public health program at the Open Society Foundation, where she manages portfolios on race, ethnicity, health equity, sexual health, and reproductive health rights in Eastern and Western Europe. And prior to her current role, she worked at comprehensive health sectors in both the US and Germany, providing health education services to uninsured patients, most of them living in precarious conditions, including being undocumented or seeking asylum. And you're going to talk to us about something extremely important, and coming back to what Deborah had earlier on said at the beginning of this moment of this meeting and webinar, that we work better when we work together. So you're going to tell us a little bit about partnerships in health equity. The floor is yours, Melody.
Thank you so much, Bernadette, and good day to all. And first, I wanted to thank Dennis and Africa Advocacy Foundation for inviting me to join this wonderful panel to celebrate the launch of My Health Europe platform today. And I also wanted to congratulate everyone involved in this important achievement of bringing My Health to life. I really look forward to the transformative impact that this first of its kind migration-led health platform will have on strengthening migrant communities' capacity to access quality health services and influence healthcare policy and practice, and so much more, including champion health as a public good within Europe. And I'm very happy that we were able to partner with Africa Advocacy Foundation on this. So I wanted to begin by briefly introducing the work of the public health program at the Open Society Foundation, and then based on one exemplary body of work, share a little bit about some learnings on the role of philanthropy in promoting partnerships for health equity. So the public health program is a global program focused on different areas of work, which include race, ethnicity, and health equity. And we manage several portfolios, as mentioned, on health rights and narrative change as well, and primarily in the geographies of Western, Eastern Europe, and then also the Balkans. And we seek to support work which transforms systems of power that discriminate against groups, including irregular migrants, but also Roma, Black people, people of color, and those living at the intersections of a host of marginalized identities impacting their health and well-being. We also recognize that social and structural factors such as environmental pollution, access to public infrastructure, housing, and secure immigration status are fundamental determinants of health, and that racism, discrimination, and stigma are themselves also determinants of health. So an integral part of our theory of change is therefore includes advancing equity and justice in all sectors of life, which address the root causes of health inequities and will in turn lead to improved health outcomes for all. And our work on social accountability, which supports primarily diverse Roma communities in the Balkans, reaches back over a decade. And we've been able to see significant change in the region as a result of this work. And the specific learnings we gathered on the role of philanthropy and health partnerships also represents a broader perspective within the public health program on the role of philanthropy. So while there are many differences between work on migration and Roma health equity, there are also important parallels, including compounding factors of marginalization and exclusion both communities face. And you'll also hear a lot of parallels between the visions and goals and approaches of My Health outlined earlier today. So the social accountability work seeks to organize and empower Roma communities to hold public authorities and healthcare providers accountable for medical and public health malpractice, abuse, and discrimination. And on a community level, this work has increased the responsiveness of authorities and significantly reduced coercive treatment from medical practitioners. So for example, in communities where there are up to 40,000 inhabitants and there was no healthcare provider operating in the communities, there are now a number of OBGYN doctors, general practitioners, and other medical specialists. So we see our role as really a convener and a mobilizer in the social accountability work, which led to important and unprecedented policy changes as well, including spaces for Roma and community members and health experts to input and review processes of policy documents, which very much aligns also with the policy and research working group that of migrant health experts, which is part of My Health Europe. So I just wanted to say a couple of words on the importance of data and would love to talk more about it if there are questions. So what we did with this project was also to collect data on race and ethnicity and immigration status, because the governments in the Balkans, so Romania and others, were not doing that. And we wanted to do that in order to have evidence-based information about the lived experiences of Roma communities and make visible the realities that Roma communities have experienced, but also point to the gaps in data collection and reporting on racialized and ethnic communities. And once we had this data, we were able to flag this to policymakers in the EU. And policy documents are now making explicit references to Roma communities and their situation in the EU. For example, in the Water Framework Directive and the new Roma strategy, which also includes information on environmental health and water scarcity and other social determinants. So in conclusion, I think European foundations, especially in the wake of the so-called migration crisis in 2015, often engage this question whether philanthropy should step in for European governments when they fail to provide basic services to marginalized communities. And this may make sense in as a short-term measure, especially during crises such as the ones caused by COVID-19, but it's not sustainable due to limiting resources foundations have, as well as also the absence of a structure that would hold private donors accountable. So rather, we have found that philanthropy can achieve tangible wins and sustainable outcomes through grant making, policy advocacy, strategic litigation, but also networking and convening different groups of people who are often not able to come to the same table and facilitate equitable exchange and participation in change making. Thank you.
Thank you so much, Melody, and thank you for pointing out some of those very important aspects of partnership, and we will take that with us into the discussion, where I'm sure there'll be some questions that come up. And now we have the last speaker for the panel, and we're very pleased and delighted that Professor Jeffrey Lazarus is able to join us, and he is the head of the health systems team at the Barcelona Institute for Global Health, an associate professor at the Faculty of Medicine, University of Barcelona. He's the vice chair of the board of the EASL International Liver Foundation and on the steering committee of the European Commission's Joint Action on Infectious Disease. He's author of more than 200 publications, has been a commissioner of the Lancet European Liver Commission, lead co-author of the Lancet HIV series on HIV outcomes beyond viral suppression. He's on the editorial board of the International Journal of Drug Policy, HIV Medicine, and Journal of Hepatology. And he has worked for WHO at 3 years for the Global Fund, as well as Director of Health Systems, Global and Board Chair of the Foundation AFEW International. So as you can see, he is very much the right person to address today, the webinar today and talk about migrant health and policy. Professor Lazarus, the floor is yours.
Thank you very much, Chair. I'll try and keep my remarks shorter than that introduction. Thank you, though. If I could have the slides. And thank you, Dennis, and to the organizers, and congratulations on the launch. I remember being with you in Spain, not far from where I work, a year and a half ago when we were planning this, and who would have thought that the world would change so much and get so much worse for migrants, because I felt a year and a half ago that things were getting a bit better. And where I work in Catalonia, as I'll show in a moment, the health system is working particularly well for migrants, even undocumented migrants. So next slide. So I know 2 speakers ago, the representative from WHO was, I saw, sitting in the headquarters in Geneva, and it always reminds me of what I learned when I spent 11 years at WHO. How do we understand a health system? Earlier, WHO had the different parts of a health system stacked one above the other. Here, they've put them in a circle to show the dynamic interaction between all parts of a health system, the importance of leadership and governance, but really also financing, information, service delivery, the workforce, and technology. But importantly, they put people in the center. And that was a big change for WHO a few years ago, the approach of having people-centered health systems, and migrants are people. Unfortunately, as we know, many governments do not recognize undocumented migrants as people in their countries and deny them the healthcare services they need. So that's the big challenge, in my opinion, of what we're facing in Europe right now. Next slide. One of the approaches one can take to making healthcare services more accessible, more fit for purpose for migrant populations is to take those 6 aspects of a health system that I just presented from WHO and break them down, as we did, in a checklist from the NLO, the Nobody Left Outside coalition across Europe that Dennis and the team are also a part of. I'll just ask you to click because there's some animation. You can take the different parts of a health system and ask questions to the community, to the different migrant communities, to try and involve them in re-engineering the services or developing services that work best for them. You can ask questions first of the services where community representatives involved in the design of the service, where the health and social care needs of the community taken into account. And then you can also ask these questions of the migrant population, of representatives of that community, to see if there's a disconnect between how those from the services understand their service and how those from the community are perceiving it, especially when there's been a breakdown in service delivery. Next slide. So I want to give an example of a project we're running and that the foundation is providing some technical support for. In Barcelona, we have a problem, and I think across Europe, of hepatitis B infection among certain migrant populations, largely those from high prevalence countries in Asia and in sub-Saharan Africa. So during the pandemic in November, we launched a community-based service in which we set up a pop-up clinic. We go to the community in collaboration. In this case, you see here an image from the Ghanaian community. During their religious services, every weekend, the team at IS Global goes and we provide point-of-care testing with rapid results for hepatitis B. And if the client is negative, we come back and vaccinate them for hepatitis B if they need it. And if they're positive, we help them we help link them to care and get them to the services for confirmatory testing and treatment if needed. Now, importantly, in the bottom middle here, you see where it says Cat Salute. That's the health card for Catalonia, one of the 17 regions of Spain. Now, if you don't have that card, you don't get health care. So what the government told us was that if we find people who don't have that card, that we can facilitate together with the Red Cross getting that card, which will work for a year to give them access to all healthcare services throughout Catalonia. So for me, that's the big victory of this hepatitis B project. It's not just about identifying, treating, and vaccinating for hepatitis B. It's about linking undocumented migrants and the larger migrant community, in this case, Ghanaians and Senegalese, to the health system and showing them that the government cares, that the community and society care. And doing this during the pandemic has just been a very emotional and exciting event. Next slide. We'll not go through the details of the care pathway, but unfortunately it sounded pretty easy, but this is all the different steps we have to take, going to the community, if they're positive, if they're negative, going back, so on and so forth. Next slide. So after I sent my presentation to Dennis, I opened up the news and I saw prisoners, homeless migrants overlooked in EU vaccine race. No surprise, very disappointing that this was the headline story in papers on the 16th of June, so just 2 days ago. Next. And this is the report that came out. Whoops, go back one. If you can go back, thanks, just one. And this is the report that came out that goes into the details. Again, it was just published 48 hours ago. But as you can imagine, it's reporting that as European countries vaccinate and scale up vaccination, many migrant populations are lagging behind in getting access to those vaccines, and there's no real clear policy on what to do about undocumented migrants, something we're going to try and change. And I hope everyone on this call will work with us and work together to make sure that everyone gets vaccinated as quickly as possible. Next. And so in conclusion, health systems need to be equitable, just, and effective. My words, the words of many other people, and here you see an article from Susanna Jakob, who founded and led the ECDC and then was the director of WHO Europe, together with colleagues a year ago, writing about health and migration. Will migrants share the road to recovery from COVID-19? I'm afraid to say that so far, I don't think the answer is yes. Next. And also a year ago from our team, as we were preparing to engage to work with migrants in Spain, we also wrote about the need for a just and effective response. And we're still in Spain and in so many other countries trying to keep this issue on the agenda, really for all marginalized and vulnerable populations. This is such a challenging situation, but particularly for migrants and for those who are undocumented. Thank you.
Thank you so much, Jeff. That was a very comprehensive, quickly, though you had many slides with a lot of information, but I'm sure that a lot of the colleagues here who are participating will have important take-home messages. And I think I'd like to start the Q&A with a question that would be a good question for you based also on your presentation. And this question has come in the chat from Jose Maya. And Jose says, how could we make sure that the work we do with migrants and the inequalities they face when accessing health doesn't feed into narratives of good and bad migrants, for example, healthy and unhealthy migrants? We know some governments like this narrative to create division, and we need to make sure we avoid those. So, Jeff, could you address this question?
Sure. I mean, there's interesting research also on the healthy migrant effects. In some migrant communities, they're healthier than the host population in the region, city, or country they're in. So I think this is really about talking about health for all, universal health coverage. I don't want to sound too cliche, because I know in particular settings there can be a lot of stigma and discrimination against migrant populations. But I think during, one thing the COVID pandemic gave us was my new favorite phrase, which was sort of, sort of enlightened self-interest, because we need everyone to be vaccinated. We need everyone safe from SARS-CoV-2 if we're going to end this pandemic. So we can't be talking about good and bad and right and wrong. This is really, we're all in this. And this is the first time I think we can really mean it. Often we say this, we need to help everyone with this condition or that condition. And that's about solidarity and that's about health for all. But in the pandemic, this is about also, enlightened self-interest. It's about protecting ourselves, protecting our liberties, protecting our economies. So there's really no room for that kind of narrative. And I think, the Catalan and other examples can be held up and said, look, everyone has a right to health across Europe. That's got to be the minimum we agree on.
Thank you for responding to that. I have two questions in the chat that have come from Fozia Haider, and one question before that that are for Lord Boateng. And the first question for you was, how do Black, Asian ethnic minority groups led organizations get a seat around the table? The second question was, on the 26th January, Nadeem Zahawi promised that health inequalities data for the Black, Asian ethnic minority communities will be made available. We haven't had that as yet. Would you like to address that, Lord Boateng?
Yes, I mean, so far as the minister's concerned, there are a number of areas, frankly, where the government have not delivered in this area of ethnicity and data, where we would like them to do. They have not given it the priority, in my view, that it deserves. And our role in that, and I certainly, with other parliamentary colleagues, seek to fulfill it, is to bombard the government with questions, seeking the answer to the very pertinent question that's been asked. And we are told, well, it will be published in due course. But, we are essentially being fobbed off. So my response to that is we just have to step up the action. So people need to write to their members of parliament. They need to keep up the pressure to demand the figures because they're there. They are being collected. At least we have that advantage over some of our fellow European countries. But the lesson for us all is twofold. One, simply counting isn't enough. There has to be the political will to act on the data. And two, and this relates to the question of how you get your voice heard around the table, there's no substitute for demanding it and for direct action. I mean, let's be very clear. I remember myself as a lawyer in the 80s participating in a picket of a mental health commissioning group on the issue of Blacks and mental health, because they were not making funding available and they were not taking the issue seriously of failures in the treatment and support of Black people living with mental illness. So we went down to where one of the committee's meetings was being held, and we stood outside with banners demanding that they respond. That's what we had to do. We also had to organize within the political parties and within the system to make sure that there were people from the Black and minority ethnic community and service users sitting at those tables by right. There's no substitute for that. No one is going to wake up one day and say, oh, wouldn't it be nice to have a patient group sitting around this table? Wouldn't it be pleasant to have a Black or minority ethnic man or woman sitting? That's not how it happens. It only happens because people demand it. That's my experience. If there was another easier way, please tell me about it, but I don't know it. And I don't pretend it's easy, frankly. You know, all of us, all of you around this table bear scars of the struggle that you have engaged in order to have your voice heard. And I'm afraid I can't tell any young person that they won't still have to continue to bear those scars. This is an ongoing struggle. We've made some gains, but there's still more to do.
And I think that having this particular webinar is part of still more to do and miles to go before we sleep. So thank you for that. There's a very interesting question that has come up in the chat and has been, I will just read out the answer from Temur with regard to ethnicity. Among the epidemiologists and researchers, this has been a challenge in Europe because some countries collect data on migrant status, and in the UK and the US, it's ethnicity and race. And this causes some concern as well as difficulties in comparing data across board. So Temur has responded saying very few countries to collect data on ethnicity. UK and the US calls it, of course, race. So we focus on the variable country of birth, which is what a lot of European countries do, or migrant status, and use that as our definition of migrant. And then Melody would like to comment about this discussion in Germany. Melody?
Thank you, Bernadette. Yeah, I just want to say a few words because we're debating this right now in Germany. And one of the issues is, how do we define a migrant, right? I think every country does it a little bit different. And in Germany, we define it as a person whose parents or grandparents has migrated to Germany. But that doesn't necessarily mean that it is adequate in documenting experiences with racism or ethnic discrimination, right? Because we have people whose parents did not migrate and they still experience ethnic or racial discrimination. And we have people who migrated from Austria, for example, and are white and don't experience racial and ethnic discrimination. So there's a little bit of a disconnect. But what's happening is that initiatives are taking matters in their own hands. So for example, there's a grantee that we're supporting called Each One Teach One. I'm sure Moro knows them as well. And they're starting a Afro census. So they're collecting data on the experiences of Black people in Germany in various sectors of society, because the German government has been so slow and unresponsive to these calls that have been going on for decades now. And their argument is often that, there's a problematic history with Germany. So they're using sort of this argument around data was in the past collected to discriminate and abuse racial minorities as a smokescreen to not engage in this conversation. So we're awaiting the results of this Afro census that's going to be published next year. And I think it's going to be a very powerful tool to have this data and to present it in various forums and use it as a tool to pressure the government also to engage with it and respond to the outcomes.
Thank you, Melody. That was very important, and I think this is, this is not the last word on this issue, and I think we're going to be continuing with the discussion and trying to get consensus on how to deal with these challenges as they appear. I'm very glad you did refer to Moro because, if you've noticed in the chat, there have been accolades, and everybody really appreciated your sharing and said it was wonderful and thanked you. And I have a question for you. And the question is, what would be your advice to all those migrants and all the people who are suffering or at the end of xenophobia and racism? What would be your advice, Moro? What would you say to people? How have you managed, through everything that you have gone through? Moro?
Thank you so much. Strategically, I think what I always respond to that question is, is always by speaking it out. I mean, not everyone like me, of course, who wants to speak every time about what I've gone through, my stories and challenges, but what I encourage my people to empower them is, hey, let's come together. And there are so many strong networks here, individually, collectively. Let's come together and let's share our stories. Let's try to put them out and build a network. But I think it's this systematic fear that is in us that I have already mentioned. Someone who went through all these difficulties came here with all the expectations and been in these isolated camps in lagers. So every day been threatened. So they are very scared to get out from this. I personally took myself out of this camp after living in this camp for just 2-3 months. I got out from there. I came to Berlin and I stood up and I joined my friends, comrades. We built a community and we are speaking it out. So, but I mean, it's hard. It's definitely hard to encourage and empower them to get out from. I don't blame them. I blame the system that put that fear into them, that makes them vulnerable. But I think if there are many communities like us and African communities or POC communities who are there, going them to approach them and to wipe this fear away from them, bring them in and share their stories and their problems and challenges, this would be a very, very good empowerment. Yeah.
Thank you so much, Moro. And it's always very good to end on a positive note, because often when we talk about issues related to migrants and ethnic minorities and racism and xenophobia, one tends to be very depressed because it's a lot of gloom and doom. But it's very important to see how people have overcome that. And I think that's really important. And it's also very good to be ending the webinar on a positive note so that we can all look forward. I know there are some questions, particular questions that I don't think we have the time to answer, but I've sort of taken it upon myself to say that all answers that won't be answered, Dennis will answer them. That's part of his mandate. So those of you who have not got any answers, please refer them all to Dennis and he will try to find the answers, if not the answers. And then unfortunately, all good things must come to an end. And we're very pleased with us that for the closing remarks, we have Sukaina Johar. And Sukaina Johar, she is the chair of the Africa Advocacy Foundation. She spent her early childhood in Kenya and then moved to London. She's a trained nurse, the British Army, qualified late in public health, worked as a public health specialist in sexual health and HIV, working in Lambeth, Sawar, Wisham, where her role included supporting African and faith communities in HIV prevention and health promotion. And after retiring, she has continued to work as a VSO volunteer in Vietnam, and she is the chair of the Africa Advocacy Foundation and actively involved in work with Muslim communities. So the floor is yours, Sukaina.
On behalf of AAF, I would like to give a big thank you to all of you who have given up your time today to join our webinar, and also to our team of panelists who have so eloquently highlighted the issues facing migrants across Europe. And on the theme of saying thanks, I want to give sincere thanks to our many funders who have made today possible. Migration and health is such an important issue, and so many people are suffering in silence. My Health, by bringing together the organisations that work with migrants across Europe, means we can really start to tackle the health and social and economic factors which impact upon the health and well-being of migrants. And picking up on what Paul said, there is strength in unity. It means our voices will be heard and can have real influence. Together we can meaningfully promote equality and try and ensure people who are usually left behind, particularly in the current, often hostile political climate, will be able to access adequate health and social care services. And I'd like to conclude by reflecting on the words of John Dryden, which Deborah quoted, which really impressed me. After lying and bleeding for a while, it's now time to get up and fight again. So thank you all so much, and I hope to meet some of you again. Thank you.
Thank you so much. And on that note, I would like to turn it over to Dennis for any final comments.
Thank you, Bernadette. Thanks everyone who has joined. If you have any questions, please do reach out to me and I will pass them over to the panelists to answer. We look forward to working with you, and thanks again.